Hello, YouTube. It has been quite some time since I have uploaded anything. I think it's almost been a year, maybe a little bit more than a year. I'm very sorry about that. Life has been very busy with school. I'm in nursing school, and it's a very demanding program, and I haven't found a lot of time to make these videos, and I haven't really had a lot of motivation to make these videos, but I've really wanted to come back and make some more. But I also don't want to pull away from my time for my classes, so I haven't really figured out what exactly, my rhythm is with ASMR. I don't really know what kind of videos I really like to make. I've made multiple different kinds, so this one is going to be a video of me studying, basically. I'm going to go over my notes, read some of my notes to you guys, and stuff like that. It's what I plan to do. This is my iPad, my school iPad. The nursing program that I'm in, they require that you get an iPad through them for taking testing purposes and stuff. So what I'm going to be looking at today is mostly my notes for my critical care class. We have a test coming up next Thursday. So for this class, I use my PowerPoints that I wrote my notes on. I also have note cards for some of the drugs. And we are going to do, there are, let's see, 1, 2, 3, 4, 5. There's 5 PowerPoints for this test. Sorry if you hear any background noise. I have 3 dogs in here. So I think we're gonna go over MI first. Okay. So I will basically just be reading off the slides. So this first PowerPoint is about acute coronary syndrome and myocardial infarction. The first slide is an anatomy picture detailing the right coronary artery and the left coronary artery, which breaks off into the circumflex branch and the left anterior descending. The next slide goes into what these structures supply blood-wise. The right coronary artery supplies 90% of the inferior wall of the left ventricle, 55% of the SA node, and 90% of the AV node. The left anterior descending, which is part of the left coronary artery, supplies the anterior wall of the left ventricles. And the circumflex branch supplies the lateral walls of the left ventricle. The next slide is about relationships between coronary artery disease, chronic stable angina, and acute coronary syndrome. Basically, how it breaks it down is coronary artery disease can be broken down into 2 separate things, and that is chronic stable angina, which means that it is chest pain that is kept in check by pain medication, or like nitroglycerin or morphine. And then acute coronary syndrome. And acute coronary syndrome can be broken down into 3 different things. So we have unstable angina, which is chest pain that does not respond to medications. However, the patient's blood work looks normal and their rhythm charts look completely normal. There's nothing unstable about them. And then we have what's called an NSTEMI, which is a non-ST segment elevation MI, which presents as normal blood work, but the cardiac rhythms show a depression in the T wave, usually. And this is very indicative of something like myocardial ischemia, so not enough oxygen is getting to the heart to perfuse the heart. And then we have STEMI. And STEMI is a ST segment elevation MI, and that means that when you look at the cardiac rhythm, the ST will be high. It's usually in baseline, and if it's high, that is very indicative of myocardial injury. So that ischemia has progressed into tissue that is now starting to become injured because it no longer is receiving enough oxygen. Alright, the next slide is a review on stable angina. So stable indicates the fixed lesions are within less than 70% blockage, so it has adequate supply. And ischemia, it occurs when the O2 demand exceeds the supply. So, and when this happens, the myocardium switches to an anaerobic metabolism for energy production, and that produces lactic acid, which is what causes the chest pain. Let's see. Patients will usually describe this chest pain as my usual chest pain. Our treatments for it are aspirin, nitrates, beta blockers, ACE inhibitors, and statins. That's about it for that one. Alright, so this is the progression of acute coronary syndrome from unstable angina to STEMI to non-STEMI. So usually these occur from plaque. So plaque is already built up in the coronary artery, and the plaque will rupture, causing the platelets to aggregate, which causes more thrombus to form, which prolongs ischemia, and which can lead to a partial occlusion, which will lead to unstable angina, or a total occlusion, which will lead to an MI. The rule of thumb for nursing is that you want them door to bed in 90 minutes. You need to have surgical or medical intervention in 90 minutes, because within 120 minutes is when it will start causing injury. The major goal of treatment is to match the O2 supply with the demand. There's also something called zones of damage, and it appears on a picture of the heart, and ischemia is a light purple, injury is a dark purple, and necrosis, which is dead tissue instead of dying tissue, which is injury. Necrosis is actually dead tissue, and that is the very center, and it is red. Okay. The number one symptom of MIs or angina is chest pain, and it is not associated with respiration, so when a patient's breathing in and out, the chest pain does not change. It does not ease with expiration. The classic location is retrosternal, so right here in the chest, and they sometimes complain of it as someone sitting on their chest. Sometimes people will mistake it for indigestion or heartburn, and it can radiate to a lot of different areas like the arms, the jaw, the neck, the scapula, or just pressure on the chest. Some things that can be noted with an MI is that they will have a systolic murmur, and you will hear an S4 sound. Alright, so this is implementing ADPI, so assessment, diagnosis, planning, implementation, evaluation. So your planned interventions for an MI are give nitroglycerin. Implement the plan is actually giving the nitroglycerin, and outcome is seeing whether or not the nitroglycerin helped with the pain at all. If the pain is refractory, which means that it's not going away, so unstable angina, that means you need to notify the healthcare provider because it could mean a STEMI or a non-STEMI, and those are both forms of heart attacks. Alright, one of our interventions, this is one of the ways that we actually diagnose MIs, is a 12-lead EKG, which is exactly what it sounds like. It's 12 leads that are placed on you. One is on the left arm, one is on the right arm, one is on the right or the left or right thigh, and 2 each on the leg. And then there is a V1 through V6, which is placed around the heart. And these are very good when looking at a MI patient because each one is set to a specific part of the heart, and so when you're looking at a 12-lead EKG, you will have 12 different lines that have different cardiac rhythms, and it will help you determine where exactly the damage is. And as I said earlier, if you see an ST depression or a T-wave depression, it means ischemia, and if you see a ST elevation, it means an injury. Okay, so MI locations and what most likely are the complications of those. As we said earlier, the right coronary artery feeds the inferior wall of the left ventricle, which, when there are problems with it, it can usually mean an AV block. And the left anterior descending feeds the anterior wall of the left ventricle, and it is usually associated with pump problems, low blood pressure, or cardiac output. Finally, the circumflex branch feeds the lateral walls of the left ventricle, and it's also associated with pump problems. There is also another form of it called right ventricular, and this can only be found if we used right precordial leads, because usually precordial leads are put on the left side of the heart, and it's associated with a pump problem, usually the preload. So some things about right ventricular MIs. You usually use the V4 is where you see it, the V4 lead. Our treatment for this one is a fluid bolus to try and increase the preload. And we want to avoid vasodilators. We want to keep that pressure up so that we have a higher preload. So we want to avoid things like diuretics, morphine, and nitroglycerin. Alright, this is the thing I couldn't think of earlier what it was called. Cardiac biomarkers. These are the tests that we do to help diagnose MIs. However, we try not to use these as the sole diagnoses, as these sometimes, depending on when the patient comes in, these cardiac biomarkers can be low for what the patient is experiencing. A patient could be having an MI, but they came in as soon as they started feeling that chest pain, and so the body hasn't had time to up these levels in the body. And so we try not to use these to diagnose. Instead, we try to use 12-lead EKGs and diagnosis by symptom. That being said, these markers are the myoglobin. The earliest increase for it is 2 to 3 hours. The peak is 3 to 15, and it returns to normal after about 24 hours. And then we have a CKMB. The normal is 3% to 5%. We never use this as an isolated test. Its earliest increase is 4 to 8 hours. Its peak is 15 to 24 hours, and it returns to normal after 2 to 3 days. This is the most important one is troponin I. Usually it's less than 0.5, and we're very suspicious if it makes it over 0.5. Usually 2.3 is very likely of an MI. And this test is one of the best tests for it because troponin I is only found in cardiac muscle. And then the last one is a troponin T, and it's usually 0.1. And that is it for the first half of MI. going to go ahead and go into the second half of MI. This slide is just saying what I said earlier. We try to diagnose off of 12-lead EKGs and clinical symptoms instead of cardiac biomarkers. This next one is the ACS algorithm. So the first thing we do is we read the EKGs, we provide interventions first, like EKGs, vital signs, oxygen if needed, specific drugs if needed, and then we read the EKGs to determine if it's STEMI, non-STEMI, or normal ST segments. So how we treat STEMI. So if we've diagnosed that a patient is in STEMI, we want to do what is called a PCI, which is percutaneous coronary intervention. And this is the thing I was saying earlier. It's door to balloon. It's called door to balloon, and then we want it within 90 minutes because of the perfusion issues with the heart. Okay. And then there's another one called door to needle, which is less than 30 minutes. We want it done in 30 minutes, and it's fibrinolytic therapy. Okay, so basically what PCI is, it can be in the form of a balloon stent, or they can actually do an arthrodectomy. But how it works is there's a guide wire placed into the heart. It goes down to where the blockage is, and sorry, that's my baby's being loud. It goes down into the heart, and it blows up, and what it does is it pushes all that plaque to the side to allow the vessel to expand, to allow more blood flow. And there's also, that is a balloon. The stent is like a wire mesh that expands. Alright, so some interventions that we do before the procedure is we like to do labs like CBCs and clotting studies, because we are going into these people's veins. We really don't want their clotting studies to be low because we want a fast clot time. We don't want them to bleed. We want to check the renal function, their BU and creatinine, because the dye that is used in that therapy is nephrotoxic, so that means that it is toxic to the kidneys. The patient will be, some teaching is going to be, they will be sedated but awake. The dye may be warm and they may feel flushed. They will lay flat with their legs straight, and they will have electrodes connected just in case of a dysrhythmia occurring while on table. During the procedure, we want to give aspirin and Plavix. Plavix and systemic anticoagulants. We don't want them to bleed out on us, but we also don't want to cause a clot, so we do have to keep their clotting factors kind of low. And there is emergent drugs ready on standby on the side. Some complications that can occur from this therapy are dysrhythmias, like premature ventricular contractions, ventricular tachycardia, ventricular fibrillation, AV blocks, dissection of the coronary artery. MIs can happen on the table if they dislodge a plaque. Stroke also from dislodged plaque. Abrupt closure and allergic reactions. Okay, so after the procedure, you have to pull the sheath out, with the guiding sheath that went in. And this has to be done by a licensed professional. The cath lab personnel will remove the sheath after activated clotting times have exceeded 150, gotten less than 150. Because we want them to clot fast. We don't want them to have a long clotting time if we're pulling, because these sheaths are very large, so it's a very large hole in the vein. It may cause the client to have vagal or vasovagal reactions. And basically what these are they cause the heart rate to decrease substantially. So we may give something like atropine, IV push. It's given for slow heart rates to increase the heart rate. Alright, and after procedure, we mostly want to assess for bleeding, vital signs every 15 minutes or as needed. We want to assess the dressing. If there's a hematoma, one of the things we don't think about maybe would be retroperineal bleeding, so we want to check their back. And we want to do neurovascular checks constantly to ensure that they're perfusing well. And their activity will be per the healthcare provider's orders. Usually they'll have their legs straight for 6 hours after this procedure. And we will continue to assess chest pain, cardiac rhythms. Okay. So the fibrinolytic agents, we basically just want to start these within 30 minutes of when the patient walks in the door. These drugs end in ACE because they are enzymes, actually. So Activase, tinkinase, if the therapy was successful, we'll see a reperfusion dysrhythmia. The ST segment will go back to baseline. Their chest pain will cease. And the CKMB will actually, the biomarker will actually rise dramatically. It is called the washout residual. Okay, some client education for MIs. One of the big things is we need to decrease their fat less than 30% of their calories. Their total cholesterol should be less than 200 milligrams per deciliter, and their LDL should be less than 70 milligrams per deciliter. We want to teach to stop smoking. We want to teach to reduce their sodium intakes, control their hypertension and diabetes, increase their physical activity, and possibly achieve ideal body weights. And then some medication teaching for things such like nitroglycerin. You want to keep it in the same bottle it comes in. You don't want to expose nitroglycerin to light. You have to be very careful with it because it absorbs through the skin. Okay, some complications of MIs are dysrhythmias, structural complications, congestive heart failure or pulmonary edema, and cardiogenic shock. So one of the structural complications is pericarditis, which is inflammation of the pericardial tissue. It can occur during or after. When listening with a stethoscope, you'll possibly hear a friction rub. But it can also cause pericardial effusion, which is fluid in the pericardium, and that will actually cause them to lose that friction rub. All right, and then we have papillary muscle rupture. It occurs when infarct involves areas around one of the papillary muscles that support the mitral valve. It's very rare. It results in the mitral regurgitation, so blood actually doesn't push all the way through the mitral valve. It comes back. And a sudden onset of a systolic murmur. And we want to treat this with vasodilators and intra-aortic balloon pumps. Alright, then we have ventricular aneurysm. It's a circumscribed non-contractile outpouching of the left ventricle. The area bulges during systole, stealing some of the left ventricular stroke volume during each systole. It's seen in about 12 to 15% of acute MIs. Some complications of it are VTAC, acute heart failure, systemic emboli. Treatment is managed congestive heart failure and aneurysectomy. Alright, and the last one, complication for MIs, is ventricular septal defect. It causes a rupture in the interventricular septum, so there's a hole between the two ventricles. It's very rare, 1 to 2% patients. It leads to acute heart failure, cardiogenic shock, and death. Symptoms are severe chest pain, syncope, hypotension, sudden hemodynamic deterioration, left to right shunting of blood, hollow cystic murmur, and thrill. It is a medical emergency, and we treat it with vasodilators and intra-aortic balloon pumps. And that is actually it for MI. And I think I'm going to stop here. There is one more after this, but I feel like this has been long enough, and I need a break. So please tell me if you like this video. I wouldn't mind doing more of it because it would help me study for my tests. So thank you guys.